Thank you to IPAC for inviting me to share some of our experiences here in New York City in regards to working on the front lines and thinking about some of the direct risks and lessons learned. So the title of today's talk is Frontline Health Workers and Direct Risks, Lessons from New York City. I'm at Albert Einstein College of Medicine and Montefiore Health System, which is located in the Bronx, New York. Bronx is one of New York City's 5 boroughs and among the poorest urban areas in the United States. I have no disclosures. So I'd like to begin by just briefly going over what the epidemic has looked like over the last, since March, since beginning of the COVID pandemic in the States or in New York. So as you can see here, in early March, at that time, we had no known cases of COVID or no diagnosed cases, and it quickly accelerated within the city to over 5,000 cases per day in terms of the 7-day rolling average. And this has been among the highest globally and in the world. And there's other studies and other individuals who have spoken at length about why this may have happened. I mean, we're still learning a lot about it, but in part due to the high rates of international travel, the high rates of the density and urbanicity, and just so many of the complex factors in a dense urban environment that likely contributed to the large case rate of COVID here in New York City. But then soon after, we had many things that were implemented at the city level. So we had essentially a shelter-in-place orders. People were staying home. Those who could work were working from home. Businesses were closed. Schools were closed, and so on and so forth. And all of these things likely contributed to a rapid decline in cases. And then since about mid-June or so, we thus far haven't seen an uptick in COVID cases. It's still yet to be determined what the future may hold, given what we're seeing globally with upticks and second waves or continuation in some cases of COVID epidemic. But for now in New York City, we've had relatively few cases on a daily basis. In terms of hospitalizations, similar to the case rate, hospitalization rates also mirrored and slightly lagged behind the case rate as we're seeing globally. And so this graph on the top right displays the number of individuals becoming hospitalized in New York City on a given day. And approximately about 1,800 individuals at the peak of the pandemic in New York City were being hospitalized on a daily basis. And this far outstripped our capacity to be able to provide care in any sort of normal circumstance, and especially pre-COVID. And I will get into a little bit later of sort of the care modifications and what happened during this time to be able to support these efforts. And just one thing to point out, as you can see at this time, very few individuals are becoming hospitalized with COVID. And what I don't know is if, to what extent these new hospitalizations represent new cases versus individuals with ongoing comorbidities or other issues or other sequelae of COVID. And these are important things to study and understand. Our death rate in New York, unfortunately, also mirrored our case and hospitalization rate. And we had amongst the highest deaths globally during a given period of time and in the US. And fortunately, we are not experiencing that at this time, and we have very few deaths currently. But this bottom left graph shows the number of deaths on a daily basis in New York City since beginning of March up until very recently. So what I'd be remiss to not mention how the COVID pandemic in New York City has really been just yet another case study in disparities. So on the map that you see on the diagram on the left is a schematic of New York City and the 5 boroughs. So New York City is made up of 5 boroughs of Staten Island, Brooklyn, Queens, Bronx, and Manhattan. Manhattan tends to be the wealthiest in terms of per capita income and in all other measures, whereas the Bronx is the poorest borough in the region. Queens, Brooklyn, and the Bronx also all have high rates of immigrant population and low-income populations. This map on the right now shows disparities in COVID case rate in New York City. So as you can see, the darker areas represent more case rate per 100,000 individuals, and the lighter shades of pink or purple represent lower case rates per 100,000 individuals. So as you can see right here, New York City in Manhattan particularly had among the lowest rates, and as well as neighborhoods in Brooklyn had the lowest rates of COVID cases. And these neighborhoods represent some of the wealthiest areas of the city, as well as having the highest proportion of white individuals and lower proportions of Latino and Black individuals or other racial and ethnic minority populations. The Bronx, which is represented up here, has one of the largest, is primarily over 90% Black and Latino or Latina. And as you can see by the neighborhoods here, these neighborhoods experience extreme rates of cases. So these were over 4,500 cases per 100,000 individuals. In terms of deaths in New York City, unfortunately, as of August 28th, the map similarly shows trends in or disparities in death rates across the city. And there's wide variability with regards to who's dying and who's not dying from COVID, or who has died and who hasn't. So the darker areas, once again, in Bronx and parts of Queens and areas of Brooklyn, represent some of the highest death rates, in New York and in the United States from COVID. And again, people who are poor, or communities and neighborhoods which are poor, have experienced among the highest death rates, relative to other parts of New York City. And where I work at Montefiore Health System, Albert Einstein College of Medicine, is located and serves the population of the Bronx. And our hospital's demographic characteristics, or the demographic characteristics of patients accessing care at our institution reflect that of the Bronx population overall. As if you visited New York, you may recognize some of these images. So on the left is Times Square, and it's a dense, crowded urban environment with lots of activity, lots of vibrant, lots of things going on at any given time, lots of activity, and lots of interactions among individuals. And similar to what's happened globally, we essentially experienced things closing up, and this was late March, early April, when these images were taken, display just what happened. And as you can see from the prior pictures, similar to what's happened globally, the city shut down, and in a way that, people in New York have never seen this previously. Similarly, with the shutdown came lots of challenges to a large, complex city. And these challenges had implications for healthcare provision, what frontline workers and essential workers were able to do and not do, and what essential businesses were able to do and not do. to respond to this challenge of just this huge surge of COVID in New York City, the city partnered with other authorities to rapidly expand capacity to provide care. So on the left is a US military ship, or basically a floating hospital that was docked in New York City for some time to provide beds. And this ship contained many beds to take care of both COVID and non-COVID patients. On the right is a very large convention center, which was outfitted by the US military to essentially mirror sort of field hospitals, where we had rapid expansion of hundreds of beds that were urgently needed and were likely indicated given the trends experienced in early or in late March. At our own hospital, we similarly went rapid expansion. So we normally take care of 1,500, across our Bronx hospitals, we have around 1,500 beds or so. But to meet the immense demand, we had to rapidly expand and shift how we operated. So what you see on the left is a conference room that at normal times were used for lectures and any other sort of group gatherings. On the right, that same area had been converted into wards and hospital beds to provide care for patients. And, throughout our hospitals, whether it was cafeteria dining room to outpatient centers to essentially anywhere we could find space, places were converted to providing care for COVID patients. And what happened during this time was nearly 100% of our patients admitted to the hospital all had COVID during March and April. We had never seen this before. Patients were lined up everywhere, and just to meet this immense capacity, healthcare workers, has been a great toll on healthcare workers, which I will get into in a little bit. Out physicians and nurses and front desk staff, and just thinking about all the individuals who are providing care on the outpatient settings were also pulled in and partnered with those who have been providing care on the inpatient side to be able to provide adequate care and staff all of these units that were created. So now I'd like to transition somewhat into talking about the impact of COVID on frontline healthcare workers and what this has meant for providing care, but what it also means for the future. And so we'll go on from there. So a couple of my colleagues published this in early June, and the article titled in Annals of Internal Medicine was a perspective piece called COVID-19, the Worst Days of Our Careers. And if you talk to many providers who've worked at our hospital or in New York City during this time, the immense toll that it's taken on us from in all sorts of respect, and I will show you some data that a rapid study has produced, which sort of highlight what these challenges have been. But these challenges have spanned from both personal level challenges and being able to think about providing the best care that we can, optimal care to our patients who are coming in front of us, as well as what it means for patients that we're not providing care for, those who do need ongoing care or chronic disease management or whatever it may be, including HIV care, and how we haven't been, or during this time, weren't able to respond to those needs, in a way we would otherwise, as well as what it means in terms of sort of both the physical and mental risks that it's sort of taken on healthcare workers. So this study by Schechter et al., published in General Hospital Psychiatry recently, highlights some of the, from a survey of healthcare workers and frontline healthcare workers, highlights some of the issues and challenges and worries in the mental health toll that it's taken on frontline workers. So one of the things you'll see here in the orange bars right in the middle of the screen here, you see some of the highest rates of anxiety being produced by worries and fear around transmitting COVID-19 to family members, the health of our family and friends, as well as the need to social distance from our families at times. So there's lots of stories of how, and reports, and this has likely happened globally, where health frontline workers have had to separate themselves from family members in order not to transmit COVID, because especially early on in the pandemic, we really didn't know what worked and what didn't work to prevent transmission in the healthcare setting. But more than that, we knew that PPE was likely helpful and worked early on, but there was challenges to obtaining adequate PPE. So, you may have read in New York and around the country in early April, there was immense challenges to obtaining PPE that could be shared or provided to healthcare workers in adequate quantities. And these were just logistical challenges related to supply issues, where things were manufactured, how things were transported, and just the sheer volume of things we needed on a daily basis and an hourly basis. And so all of this fed into, so as you can see here, majority of respondents indicated that a lack of PPE and a lack of adequate testing capacity, of COVID-19 testing capacity, produced a lot of sort of distress, which likely fed into transmitting COVID to family and friends. But then you can see that there was a whole host of other sources of distress among healthcare providers, among frontline workers. And these span from, making decisions without guidelines, early on in the pandemic, being redeployed to providing care for things you may not have done in many years or outside your specialty, providing emotional support to patients, transmitting COVID-19 to other healthcare workers, transmitting COVID-19 from patients to patients, there being sleep disturbances, working extra clinical hours, not having time for adequate rest. And so thinking about all of, childcare issues, so thinking about all of these issues and what is the immense toll that this pandemic is having on healthcare workers. This same study by Schechter et al. Also went on to survey and look at screening rates of individuals or participants screening positive for acute stress, depressive symptoms, and anxiety. And so this bar graph on the right displays 3 outcomes that were screened for. These were acute stress disorder, depression by PHQ-2, and anxiety by the general anxiety diagnostic scale, 2 items. And each of the blue represents attending physicians or licensed physicians. The yellow or the orange middle graph represents medical trainees or fellows and residents who are completing their internships and medical residencies. And the green bar represents nurses and other providers, allied professionals. And as you can see, acute stress disorder, we see essentially 2 out of 3 individuals met criteria for acute stress disorder among nurses and other allied providers. About half of residents and fellows and 40% of attending physicians. Similarly, we see similar trends across depression and anxiety. So during this period, there was just high rates of individuals screening in for depression as well as anxiety. And thinking about, what are the issues associated with having these conditions, screening positive for these conditions, and being able to provide adequate care to your patients, but also sort of thinking about your own health and the health of your colleagues and coworkers, and what this means for a systems issue. So in sort of a fight or flight response mode, we're able to provide perhaps to some degree care in the acute setting, but what is the impact on sort of what are the long-term impacts of these issues? And I think these have yet to be sort of a certain, but areas of important inquiry and study and follow-up to understand what are the long-term impacts of such, acute trauma on the health of frontline workers, as well as the health of systems providing care to our communities. Another article by colleagues at my institution, by surgeons, looking at the impact on frontline health workers. And they reflected in this recently published article just last week, reflections on COVID-19 epidemic and what happened during the first 30 days in their Department of Surgery. And so let me walk you through this graph. So what they noticed here is, so in our system, this was the daily patient census and total number of patients, as well as ICU admissions. So the total number of patients is represented by the tan-colored graphs. The number of patients in the ICU is represented by the gray-colored graphs. And the blue line represents the number of residents who are diagnosed or out of work due to COVID on a daily basis. So overall, about little bit over 1 out of 3 surgery residents were diagnosed or confirmed to have COVID. And all of these surgery residents were deployed to medical units, medical ward units, just providing, and we're not doing surgeries anymore. And we're providing, and same thing with the surgeons, we're all providing care to COVID patients. And over the course of, the first 30 days or so, there were high rate, about 1 out of 3 individuals became infected or were suspected to have COVID-19. In a forthcoming paper by other colleagues looking at medical ward or medical residents, there was even higher rates of confirmed or suspected COVID and individuals having to be out of work due to being diagnosed with COVID, likely from nosocomial infections and lack of access to sort of adequate PPE early in the pandemic here. And these trends are likely similar for across institutions in New York City. And as you can see, as our COVID case rate went up, nearing 2,000 admissions a day, or having a census of 2,000 patients in our hospital in each day, as well as the census of the ICUs going upwards nearly to 400 which before COVID, we would have about 100 patients a day in the ICU or 100 beds available total. So we had to rapidly expand, to another 200 to 300 beds. And as you can see, all surgeries were suspended, and then surgical teams were deployed to taking care of ICU patients, as well as the medical ward patients. And this happened across specialties at all, pretty much every institution in New York City. In another study that was recently published just last month, looked at prevalence of SARS-CoV-2 infection among healthcare workers in a tertiary community hospital in Long Island, which is adjacent to New York City or a suburb of New York City, which also experienced really high rates of COVID early on. And what you can see here is, there were similar rates of healthcare workers who tested positive for COVID or had antibodies to COVID by job title and department. So from environmental workers to ancillary staff to nurses, physicians, and technologists, nearly 12% of healthcare workers were infected or had been had COVID at some point early in the pandemic. And this was, in similar rates across setting types. So the emergency room, the general medical floors, the ICU, the operating room, just sort of administrative areas and other areas. So as you can imagine, for a whole entire sort of ecosystem of healthcare workers and institutions, the toll that COVID has taken on frontline staff has just simply been tremendous. Shifting gears slightly and thinking about the future and the way forward, I'd like to spend the next few minutes thinking about or discussing what the future may hold and how we may move forward from this and how people are moving forward. So in a recent narrative review and conceptual framework proposed by Dr. Schwartz and colleagues called Addressing the Post-Pandemic Clinician Mental Health, recently published about 10 days ago, looks at, proposes a framework of clinician well-being and resources, and thinking about using the eco-social model at different levels, what can be done to promote the health and well-being of frontline workers. And I will go through some of these recommendations, but essentially what they propose is at the individual level, think at sort of really putting out the fire, so to speak, thinking about immediate actions that can be taken, such as stress reduction training and resources for stress reduction, resources for resilience, and promoting and supporting resilience among healthcare workers. And what does that exactly look like is, there are models which this article addresses, and I would urge you to read this article, which is available online. At the organizational level, addressing healthcare workers' basic needs. So ensuring adequate PPE first and foremost, ensuring protocols and procedures in place, ensuring testing capacity and rapid turnaround of testing and results available, providing specialized training for new job roles. And as we're all learning and going, I think we've seen models that it is possible to rapidly deploy. Agencies in the field have been doing this for a number of years, so there's probably a lot to learn from, organizations that have been doing sort of crisis work in the field, where they've set up field units and field hospitals and implemented rapid trainings and new protocols, where we can learn from them. But providing such training for new job roles can help perhaps reduce some of that anxiety and sort of mental burden that it's taking, as well as the physical toll and burden. Organizations can recognize and communicate and provide communication from leadership, transparency, and providing adequate communication. So, frontline workers know what's going on at the institutional, as well as the community level. Addressing the moral injury. So this article does discuss to some degree, what is meant by moral injury, and there's a growing, and a few articles that have recently come out talking about the moral injury among healthcare workers and frontline workers and what that means for the future. And at the societal level, and one other thing organizations may be able to do is provide programs to encourage peer support and connection and social connection. And these are, really thinking about what are things that can be done now and in sort of the ongoing, sort of this immediate time period to really put out the fire, so to speak. So our house is on fire, so we need to put it out. But we also at the same time need to think about the future and what we can do to prevent and address the ongoing challenges this pandemic is going to pose, as well as what it's going to do to the healthcare workforce in the long run. So think about broad funding. So providing at the societal level, providing broad funding and policies that can be implemented to support enhanced mental health programs, as well as protect physical health of frontline workers. So some recommendation, this article, puts forward are healthcare workers require proactive psychological protection. So, for a while we've been highly reactive as a global health community, but we really need to think about and rapidly implement proactive psychological protection, because once, so to speak, the damage is done and sort of embedded, it's going to take a lot more effort to undo that damage, and also thinking about what the implications are for healthcare capacity globally. As institutions, providing comprehensive institutional and societal infrastructure for healthcare worker well-being, we really need such infrastructure to mitigate both the psychological and physical costs of providing care during a pandemic, but also recovering from associated experiences. So there's a lot of discussion about sort of PTSD-like symptoms and the trauma experienced by frontline health workers, and the support needed to recover from these associated experiences, and really investing now to address these experiences proactively. And thinking about where to target support. So, some immediate places support can be targeted are things such as providing resources for resilience and stress reduction, ensuring that basic needs of healthcare workers are met. And, and these can be simple things as ensuring access to meals and access to, time off, and access to sort of backup support, and access to lodging facilities or quarantine facilities, so people are able to have comfortable places and sort of adequate places to be able to quarantine themselves if needed from family members and other individuals, and sort of a whole host of other basic needs that should be surveyed locally and implemented locally. Providing routine opportunities for social connection, what that looks like in a pandemic is going to be challenging, but it's also going to vary from context to context. But, while we are essentially social beings, and this pandemic has really furthered that social connections and created social isolation, and thinking about ways systems and organizations can promote social connection in creative ways are needed. And then really to proactively normalize and deliver mental health care to healthcare workers. And I think this can't be understated. The immense toll that this pandemic has had and continues to have on healthcare providers globally, just the deaths we've experienced and witnessed, unfortunately, the isolation we see in our patients' eyes, the sort of just the anxiety and angst we see from, oftentimes failures of leadership at governmental organizations and international organizations to really provide strong guidance as to ways forward and what to do. So we really need, to proactively normalize and deliver mental health care to frontline workers. And as we do all of these things, I think we also need to sort of accompany all of these things with sort of rapid evaluations and sort of perhaps implementation science approaches to understand what's working and what's not working, so that all of us can create a sort of global community of practice or learning community that we're able to learn from one another and each other rapidly from each other's experiences. And so I'd like to close, just thinking about, this pandemic has really highlighted many challenges and brought to surface challenges globally. Here in New York City, while we're honoring and thinking about all the frontline healthcare workers that have provided care and sort of had to witness and experience this acute trauma amongst our patients, amongst ourselves, and amongst our friends and family members, thinking about what this has done at the same time for other challenges at the societal level, so racism. So during this pandemic, we've seen, really strong and needed protests and awareness raising around what's going on in our society with respect to racism, and really thinking about sort of the police violence and other sorts of violence and systemic racism and violence perpetuated sort of marginalized populations, Black populations, immigrant populations, and other groups in our country, and what this means and how these, and we're seeing these same challenges filter into what COVID has done in terms of disparities in infection rates, disparities in hospitalization rates, and disparities in deaths. But hopefully we will all come out for the better, and there are ways forward. And I think we really urgently need to work together to sort of address this pandemic and address other issues that are really sort of fueling this pandemic. And they're going to keep fueling this pandemic if they're not addressed. So would like to leave it there. But thank you to IPAC for letting me share some of our experiences and thoughts around what we've experienced here in New York City.